Good morning, everyone. We might get started. Welcome to Oncology 6, and today's session is going to be on lymphoma. I'm Paul Roach from Royal North Shore Hospital in Sydney. I'm joined up here by Professor Homer McCappin-Lack from MD Anderson in Texas. Just a reminder, if you could turn your mobile phones to silent. So our first speaker today is going to give us a clinician's overview of lymphoma, and we're lucky to have with us Professor John Seymour, who is the head of haematology at Peter MacCallum here in Melbourne. John.
Thank you very much for the invitation, the introduction and the opportunity to present an overview of this broad field. Hopefully I'll achieve that with relative depth and on time. Lymphomas are a significant public health problem, particularly in Australia. In the left panel there, you can see the increasing prevalence such that they're now the 6th most common form of cancer in our community. Pleasingly, you can see that the gap between the incidence and the mortality line is increasing, suggesting that we're getting better treatment and fewer deaths in these patients. Although that's quite variable, shown here from the European Eurocare analysis, various geographic regions showing a couple of things, both that there is variability across geographic areas, and although that there's improvement across time, that varies. So the healthcare system delivery elements around lymphoma care are complex, and I think the recent progress in treatments that I'll go through exemplify some of those complexities, and patient selection and care in delivery of the therapy is essential to get optimal results for our patients. On the right-hand panel, you'll see that there'd been less improvement in diffuse large B-cell lymphoma, and this is now relatively historical data, given that it reports 5-year survival. But after the introduction of the anti-CD20 monoclonal antibody rituximab in the early 2000s, you can see that trending upwards. And other data have shown that that has continued since that time. So these are the domains I want to touch on relatively briefly in the next 30 minutes, speaking a little bit about response criteria and some of the newer developments there, and then working through some of the classes of therapies that have shown activity in the lymphoma realm. Interestingly, and I think importantly, each of these show activity in different subtypes of lymphoma. So histopathological classification and increasingly molecular subclassification is important in selecting these therapies. So there's been a very good and collaborative approach to lymphoma classification, and this was updated at the 2013 Lugano workshop and published in 2014 from a consensus group, and you'll see Sally Barrington there, and incorporation of response criteria, and particularly integration of PET response has been integral in these criteria, and I think lymphoma has been one of the leading areas. In fact, there was a companion piece that in great detail with excellent international harmonisation, including some authors who may be in the audience here, has integrated the techniques for response assessment using the Deauville 5-point scale and around timing and performance of these studies. So there's very good integration of response in lymphoma. However, lymphoma stands out relative to other malignancies in that it still requires bidimensional lesion measurement, and this makes it distinct from the solid tumour response criteria. A group of us led by Anas Yunus began exploring whether this was justified given the increased workload, increased variability, and the difficulty around implementation of different response criteria in so-called molecularly directed basket studies that may have sarcomas, lung cancer and lymphoma. And if you're using differential response criteria, it makes it very difficult in designing these studies. So the aim was to potentially integrate with the RESIST criteria. And for the first time in lymphoma to actually base it upon data-derived assessments of the predictive capacity of attainment of various response categories. Also incorporate the pseudo-progression that Rod Hicks illustrated very elegantly, that is increasingly a part of our therapies. Also to measure duration of benefit that may continue beyond formal disease progression. So these were the goals of this so-called RECIL response criteria that had been published. And these are summarised here, looking at the relative similarities and differences compared to the Chess and Lugano criteria, and bringing them more in line with the solid tumour RESIST criteria. So probably the biggest change was utilisation of unidimensional measurement compared to bidimensional measurement. And this is a cross-validation based upon nearly 30,000 scan measurements in about 4,000 patients from 10 randomised studies, showing that there was very, very tight correlation between unidimensional measurement in the long diameter compared to the some of the products in the bidimensional, regardless of the number of lesions that were measured. Again, Chesson criteria recommends 6 indicator lesions, and the RECIL can utilise as few as 3. The second component was then looking at impact upon time to disease progression, and shown here whether by previously treated or previously untreated patients, using the various thresholds of a 20% increase in long diameter, or opposed to a 50% increase in the sum of the products of the areas, showing very, very tight and comparable time to progression, very clearly validating that these unidimensional criteria perform equivalently. So those are available, they're being incorporated into clinical trials, and depending upon particular studies, the Chesson or the RECIL criteria may be utilised. Moving on to the therapeutic domain, as I alluded to in one of the introductory slides, probably the biggest and broadest advance in the treatment of B-cell non-Hodgkin's lymphoma has been the introduction of the anti-CD20 antibody rituximab. And this has really been paradigm changing in that it's shown significant activity across all of the B lymphocytic disorders that express that surface protein. And I think it brought a sense of complacency into the field of haematology that, of course, if the target is expressed and you've got an effective antibody against it, there'll be therapeutic improvement. So many companies, including the company Roche, who developed rituximab, have been looking at improving those anti-CD20 antibodies. Now, the mode of action is across 3 potential mechanisms of cell killing, either antibody-dependent cellular cytotoxicity, complement activation, or unique to so-called type 2 antibodies, a direct cell death mechanism. It's debated which of these are the predominant mechanism of activity in different diseases and in different contexts, and so different companies have chosen to emphasise one component or the other. The most well-developed is the second-generation antibody obinutuzumab, or GA101, in the second line there. There have been a series of clinical trials that have evaluated this antibody across a spectrum of lymphomas. The first of these was in the setting of rituximab refractory disease, in the relapsed follicular setting, where conventional chemotherapy alone with bendamustine was compared to chemoimmunotherapy incorporating the new obinutuzumab antibody, as shown in the yellow line. Now, that was both in induction and then with maintenance, so a somewhat imbalanced paradigm of chemotherapy alone compared to chemoimmunotherapy plus maintenance. Regardless, the progression-free survival, and if you focus on the right-hand panel, particularly in the subset of patients with follicular lymphoma, was substantially improved, and on more recent follow-up, there's been improvement in overall survival in follicular lymphoma. This has led to licensing of obinutuzumab, at least in the United States, in this setting, although a number of people felt that it was an unfair comparison comparing chemoimmunotherapy with maintenance to chemotherapy alone. So in the frontline setting, perhaps a more balanced comparison has been completed, and this study we published in the New England Journal with Bob Marcus as the first author late last year. And this was physicians' choice of chemotherapy backbone, although it was predominantly CHOP chemotherapy, and then a randomisation to the rituximab, the established antibody, or obinutuzumab, GA101, so R chemo compared to G chemo, with 2 years of maintenance using the same antibody in all of those patients. So a far more balanced outcome. The primary endpoint here was progression-free survival, and you can see nearly a 34% reduction, so a hazard ratio of 0.66 in PFS, leading to about a 7 or 8% improvement in 3-year progression-free survival. That did not come without a toxicity burden. There was an increased risk of both febrile neutropenia as well as overall infections, and also an increased rate of infusion-related reactions with the newer antibody, such that a few percentage more patients had to discontinue treatment because of toxicity. So clearly a more effective anti-follicular lymphoma antibody than rituximab, but with, to my view, acceptable but increased toxicity associated with its use. Now, as I mentioned, rituximab had been paradigm changing in that it showed improved efficacy across all of the spectrum of CD20 expressing lymphoproliferative disorders: chronic lymphocytic leukemia, mantle cell lymphoma, follicular lymphoma, and diffuse large B-cell lymphoma. But obinutuzumab has illustrated that the response to different antibodies may differ across this disease spectrum. So this was a companion study to the gallium study that I just showed in follicular lymphoma, now looking at diffuse large B-cell lymphoma with the same design, CHOP chemotherapy backbone, and then randomisation to either rituximab or obinutuzumab as the chemotherapy partner. And here you don't need a PhD in biostatistics to show that those progression-free survival curves, and similarly the overall survival curves, are completely unaltered using the newer antibody. So this has broken that previous believed paradigm that a CD20 antibody would show the same magnitude of therapeutic efficacy across the disease spectrum. And so we're now in the setting of where different CD20 antibodies with the different effector profile across the various mechanisms of action are being utilised in different disease contexts. Moving on to targeted therapies, and while molecular profiling in lymphoma has been very thorough and very detailed, describing mutations, those mutations very rarely, with one exception that I'll touch on at the end of this talk, are being used to select therapies. Conversely, pathways that are activated and involved in the underlying biology of the disease are more frequently being targeted by newer therapies. One of the most promising of those pathways is the so-called B-cell receptor signaling pathway. So all of these mature B-cell lymphomas express a clonal immunoglobulin on their surface that recognises antigen, and that signals this B-cell receptor pathway. And there are two significant nodal points. One is at the direct activation of that pathway that signals through BTK, or Bruton's tyrosine kinase, and the second is through the PI3 kinase pathway. So looking at the first of those, BTK, ibrutinib is the first molecule that was developed. This covalently binds to a particular amino acid, the C481 amino acid, in the ATP binding site within ibrutinib, and leads to inhibition of its kinase activity. Although it's labelled a BTK inhibitor, ibrutinib is not a pure BTK inhibitor, and you may be able to see in the table that it acts on other related kinases that are also involved in T cell function and natural killer cell and macrophage function. Again, the spectrum of these agents varies across different diseases, and the B-cell receptor inhibitors, particularly the BTK inhibitors, show greatest activity in mantle cell lymphoma and in small lymphocytic lymphoma. While nearly 2/3 of patients eventually will attain a response with ibrutinib, shown here in mantle cell lymphoma, there's a number of elements of this therapy that are particularly noteworthy. The first is that continuous treatment is needed. So this is a suppressive therapy rather than an eradicative therapy, and a corollary of that is that the vast majority of responses are partial rather than complete. So this is shifting these diseases into a chronic chronic therapy model. The next element to take note of, and it will become relevant when we look at some combination therapies, is that the responses are relatively slow to be manifest. So at that 4-month time point, you may be able to see that less than 10% of patients have achieved a complete remission, and the overall response rate is only about 50% at that time point. So we'll be using that as a benchmark for comparing some combination therapies subsequently. We had hoped that, unlike chemotherapy, where we lose potency with successive treatments, that we may be able to, with these targeted therapies, see efficacy across all lines of treatment, regardless of extent of prior chemotherapy exposure. That hasn't been the case in multiply relapsed patients, whether measured by progression-free survival or overall survival. We see diminishing efficacy with increasing chemotherapy exposure. Moving from mantle cell lymphoma, where ibrutinib has established a very substantial place in treatment, ibrutinib has negligible activity in follicular lymphoma. You can see the quite disappointing progression-free survival curve on the left-hand side, such that the median in the relapsed setting is well under 6 months. However, intriguingly, the small proportion of patients, 19% of patients who do attain a response, that response is relatively durable, but we're currently unable to identify the characteristics or predict that subgroup of patients. So ibrutinib and BTK inhibitors more generally have not established a role in follicular lymphoma. The situation in diffuse large B-cell lymphoma is somewhat more complex, and this is data from a very influential Nature Medicine paper from Wyndham Wilson. And perhaps if you look at the top right-hand panel that breaks down responses by cell of origin subset within diffuse large B-cell lymphoma, and superficially this looks very promising, such that more than 40% of patients with activated B-cell type attain a response, compared to 5% in those with germinal center subtype. And this has been the basis for a very large randomized study enrolling nearly 1,000 patients, which has been completed. Conversely, to my view, this is less promising than some may interpret. If you look at the bottom left panel, even among the more responsive activated B-cell subtype, the duration of response, or the progression-free survival, is really quite brief. And so the capacity of these even initially responsive cells to develop resistance mechanisms is very prompt. So I've got some doubts about the role of BTK inhibition in diffuse large B-cell lymphoma, but the randomized study will clarify that. The second pathway in the B-cell receptor response is that of the PI3 kinase pathway that feeds in through AKT and then into mTOR, which is one of the growth signals involved in lymphoma. There are many attempts to target this pathway at multiple levels, but the most mature and the location which has led to marketed drugs is at the PI3 kinase level itself, and agents under investigation are listed there. Now, this is a complex signalling molecule where there are multiple isoenzymes, many involved in very fundamental cellular processes. And so there's a tension in the field between the broad PI3 kinase inhibitors that may have greater activity but far greater toxicity compared to the isotype selective, predominantly the delta isotype that's particularly involved in B-cell receptor signaling. Given the pleiotropy of these actions, while there's a direct tumour cell killing activity, many of these PI3 kinases also putatively act through microenvironmental signals and acting on regulatory functions of other B and T cells and signalling chemokines. So idelalisib, a selective PI3 delta inhibitor, is the most mature, and it's one that's gained marketing approval both in the US, Europe and Australia in small lymphocytic lymphoma and also in follicular lymphoma, but other PI3 kinase inhibitors are under development. This was the pivotal study, a single-arm study that led to the registration. This is in a subset of patients where the disease had been shown to be refractory to alkylating agents and anti-CD20 antibodies, and the overall response rate was 53%, with the median time to progression approaching a year and an overall survival just under 2 years. Modest improvements, but useful contribution to a subgroup of patients with otherwise refractory disease. The promise of these agents is partially in their own activity, but also if we understand their mechanism of action, selection of combination partners. And there was preclinical data showing significant synergy with chemotherapy with these PI3 kinase inhibitors. However, this is a small pilot study randomizing between the PI3 kinase inhibitor with chemotherapy, with rituximab monoclonal antibody, or with chemoimmunotherapy, failing to show marked improvement with either of those combinations. So fulfilling the potential promise of combinations is remaining problematic. The second issue with these PI3 kinase inhibitors, possibly through the pleiotropic actions that we spoke about, is a spectrum of newly emerging and somewhat difficult to manage toxicities related to immunosuppression and opportunistic infections, including PJP and CMV reactivation, as well as colitis that may be through inhibition of T regulatory cells. And through a similar mechanism, autoimmune hepatitis and autoimmune pneumonitis. So these toxicities, both as a single agent, are important to be aware of, but also make development of combination therapies problematic. And this is illustrated here from a pilot study performed, led by Nathan Fowler at the MD Anderson, looking at preclinically what was predicted to be a relatively safe and effective combination of lenalidomide, idelalisib, and rituximab. However, unexpectedly, 2 of the first 7 patients died from severe hepatotoxicity. So some of these difficulties with combination have calmed and perhaps delayed the development of these combinations, particularly with the PI3 kinase inhibitors. The other group of drugs that I've had significant involvement in that's showing promise in the B-cell lymphoproliferative disorders are those acting on the apoptotic pathway, particularly BCL2. So BCL2 is expressed as a pro-survival molecule that normally leads to the delay or blockage of apoptosis and cell survival in lymphocytes. However, when a stress is experienced by the cell, pro-apoptotic molecules such as BIM are expressed, and these bind to BCL2 and then overwhelm that activity and allow apoptosis to proceed in a stressed situation. However, one of the pathways bypassing that in malignant lymphocytes is through overexpression of BCL2, so that even when these stress signals are suffered, there is sufficient overexpression of these anti-apoptotic molecules to overwhelm that signal and lead to prolonged cell survival. So it was postulated that if you could develop a molecule that would selectively mimic the activity of these stress signals, these BH3 proteins, you may be able to rebalance that BCL2 overexpression and lead to cell death. That's been very profoundly effective in chronic lymphocytic leukemia, leading to the marketing of the drug in that context. But this was a study we did looking across the spectrum of non-Hodgkin lymphoma. There's been variable activity, and probably the most promising is in mantle cell lymphoma with a 75% overall response rate, but a relatively disappointing 21% complete remission rate. And you can see the progression-free survival here, very similar activity to ibrutinib, a median around 12 months. With complete responders having far more durable control of disease than partial responders. So the goal of therapy would be to improve complete remissions attained with these agents. As I mentioned, there's evidence of synergy similar to with the PI3 kinase inhibitors here in xenografts using this BH3 mimetic venetoclax with chemoimmunotherapy. And also potentially relevant to one of the later speakers here, looking at radioimmunotherapy, venetoclax treatment sensitizes to that in a diffuse large B-cell lymphoma model. So we attempted to exploit some of that preclinical synergy in here, performed a study led by Contam at our institution of the combination of venetoclax, or ABT199, with ibrutinib. And given that I'd mentioned with ibrutinib, we see relatively few complete remissions and those responses relatively slowly, we looked for an early signal, and the primary endpoint was around the complete remission rate at the 16-week mark. That has recently been published, and we were very proud to get that into the New England Journal. I think the reason that the New England Journal was interested was that we showed very marked synergy. So overall, a 71% PET negative complete remission rate at that 16-week time point, and a single case is illustrated here to show that potency. Relatively little activity in the first 4 weeks with ibrutinib, but then profound reduction as shown in the PET scan of a very large lung mass at the 16 weeks when the patient had been on both drugs for 3 months. So minimal residual disease clearance is never achieved with either of these agents alone. And if we look down to the 10 to the minus 3 level in bone marrow, or 10 to the minus 5 or below level, using a allele-specific oligonucleotide PCR, we can see that with the combination we're seeing far greater depth of response. The other domain in lymphoma that we're seeing progress in is with the immunotherapies, and I'll not spend time on the checkpoint inhibitors described in the left-hand column because Shireen Loy has done that very eloquently, but 2 therapies that are showing somewhat specific activity in the B-cell lymphomas are those of T-cell engaging antibodies, where rather than relying on removing the brake of checkpoint inhibitors, are directly binding to both the target lymphoma as well as the effector T-cell and bringing them into physical proximity. And even more exciting, but based on more complex biology and cellular engineering, is that of the chimeric antigen receptor T-cells. And the B-cell domain is the first disease area where they have been licensed. So the checkpoint inhibitors have shown marked activity in Hodgkin lymphoma, but relatively little activity in diffuse large B-cell lymphoma, and it's restricted to particular disease subsets. Primary mediastinal B-cell lymphoma with about a 40% response rate. Very excitingly, T-cell or natural killer cell lymphoma with a very high response rate, and primary or relapsed central nervous system lymphoma. T-cell engaging antibody, and blinatumomab is the first in this class, is showing significant activity in diffuse large B-cell lymphoma, as well as being licensed in B-cell acute lymphoblastic leukemia. So I mentioned the chimeric antigen receptor T-cells, where a viral vector is used to transduce both the anti-CD19 surface receptor into T cells linked to a co-stimulatory molecule that lead to the expression of this CD19 recognition domain on the surface of these T cells and direct them towards tumour cells. There's been 3 products under development, and 2 of those have recently achieved FDA licensing in the United States, the Kite product and also the Novartis product. And you can see in early trials here the profound reduction in otherwise chemotherapy refractory diffuse large B-cell lymphoma, with short follow-up and apparent plateau in that curve. So nearly 2/3 of patients achieving a complete response showed durable responses, which is completely paradigm changing in this disease. There are complex differences, but largely similarities between the 3 products produced by Kite, Novartis, and Juno, each of which was in collaboration with an academic partner. The production and the underlying cellular engineering is very complex, and these therapies are both very expensive to produce, as well as relatively toxic to deliver, and the toxicity profiles of a so-called cytokine release syndrome that accompanies the activation of these T cells, and a poorly explained neurotoxicity profile are a characteristic of each of these products. Regardless, as I mentioned, about 2/3 of patients who achieve a complete remission, that appears to be relatively durable, now with follow-up out to 5 years in the initially treated patients. The final agent to touch on in the last moment or two is that of tazemetostat, or an inhibitor of the EZH2 enzyme. Now, this is involved in epigenetic gene expression modulation and is mutated in about 15 to 20% of patients with follicular lymphoma. And this is the one molecularly targeted treatment that is gaining some traction in the lymphoma space. So from the phase 2 study, the activity was nearly exclusively restricted to those with an activating mutation, where the overall response rate was 92% in this phase 2 study. There still were responses, about 26% in patients without a mutation, and we're looking for other gene amplification signals that may identify this non-mutated group who potentially could respond. The other drug class being developed is that of antibody-drug conjugates, but I don't see as much promise in this space as in the Hodgkin lymphoma space, where brentuximab has recently gained registration in frontline treatment in combination with chemotherapy. So we now have a number of different tools that are showing some promise across a spectrum of diseases, and the real challenge is trying to better understand their mechanism of action, the mechanisms of resistance, mechanisms of cellular adaptation, to rationally select and then hopefully prove the safety and efficacy of combinations. I believe that we've done that using the BH3 mimetics, venetoclax, together with anti-CD20 antibodies, largely at the moment in the CLL domain, and very recently with the combination of BTK inhibitors and the BH3 mimetics. But the large challenge to the community and imaging assessment and molecular targeting to confirm mechanism of action and confirm response will be a critical part of that, but the rational selection of those combinations is the next element that we must face, and hopefully with a clear understanding of the mechanism of action, we'll be able to do that in a rational way. Thank you, and if there's time, happy to take questions.
John, thanks very much for that overview. It's clearly a very dynamic time at the moment. If there's any quick question, otherwise we might defer them to the end of the session. We'll see how we're going for timing. John, just before you go, on behalf of the organisers, I have something to give you just to recognise your contribution today.
Moving on, it's my distinct pleasure to invite our next speaker, Professor Wim Ooyen, who comes to us from the Institute of Cancer Research in Sutton, United Kingdom, and he is the president-elect of the European Association of Nuclear Medicine, and he will talk to us about FDG PET-CT and assessment of treatment response in lymphoma. Wim.
Thank you very much, Homer. Thank you very much, the organizers, for inviting me to Melbourne. It's always a pleasure to be here. Today I'm going to speak to you about FDG PET-CT for assessment of treatment response in lymphoma. We'll mainly be focusing on Hodgkin's disease, and if there is time, spend a few minutes on non-Hodgkin's lymphoma as well. So, this is going too quickly. Okay. The potential impact of advanced imaging, you can basically break down in a number of large categories, from staging to tumor delineation, characterization of tumors, therapy response monitoring and prediction, and eventually follow-up and relapse detection. And in lymphoma, the first staging is quite obvious, but the main impact that's been developed in the last couple of years is in therapy response monitoring and prediction. And traditionally, the role in follow-up and relapse detection is there, but it's a bit more scattered. So the focus will be mainly on response monitoring and prediction. When you look at the, the data in literature, you have to be, let's say, very well aware what we've gone through when we developed PET. So the images on the left with the 2D filtered back projection, I think the people involved in early PET development are still having nightmares on the noisy images that we had to work our way through and then try to find a node that was PET positive. And with the advancement of the kit and the reconstruction algorithms, the images got nicer and nicer, and we were able to see much more detail and much smaller involved nodes. Another point is the introduction of PET-CT, which revolutionized basically the interpretation of the images as well. And you have to be very, very conscious when you read the literature, when the studies were done, with what equipment and with what reconstruction algorithms. And you can broadly say that anything that's been done in clinical studies before the introduction of PET-CT, so you have to be very, very restrictive in taking the data from these studies as representative of what's happening today in the use of PET. The pivotal questions that we have to answer go way beyond the descriptive statistics about sensitivity and specificity. It's very nice to have these data. You need them to have a sense of what you're doing. But if you perform these imaging tests, you have to look at 4 main elements: impact on patient management, impact on patient outcome, impact on quality of life of the patients, and impact on cost of healthcare. And if you don't have a role in one or more of these broad categories, so it's very doubtful if you should even use imaging. So there has to be a decisive clinical impact on what our imaging is delivering to the patient. If you look at the lymphomas, the Hodgkin's lymphomas are virtually all very FDG-avid. In the non-Hodgkin lymphoma, it's a bit more scattered. It's very common in diffuse large B-cell, follicular, and in the less common non-Hodgkin's lymphoma, Burkitt, mantle cell, and aggressive T-cell, you have a very high proportion of patients that are FDG-avid. It's variable in extranodal marginal zone and skin non-Hodgkin lymphoma, and there are also lymphomas where there is hardly any uptake at all. You see studies that the SUV max in the lymphomas is correlated with an indolent or aggressive behavior and with the proliferation of the tumor cells. So what are the assets of FDG PET-CT? Why has it caught on so in lymphoma? First of all, the sensitivity, picking up disease in normal-sized nodes, but also excluding disease in enlarged nodes. Picking up organ localizations, especially liver and spleen, and the bone marrow involvement, replacing biopsy, the need for biopsy in Hodgkin's disease and diffuse large B-cell lymphoma in a large proportion of the patients. At staging, we reclassify approximately 20% of the patients, depending on the series that you pick. It's between 10 and 50%. We see more upstaging than downstaging. Early response assessment I will speak about later in this talk, and follow-up after end of treatment I think is a discussion of its own, when to do it or whether to do it or just to refrain from it. When you do advanced imaging, putting in a very sensitive test, you have to be very much aware of what's called the Will Rogers phenomenon, who said that when the Okies left Oklahoma and moved to California, they raised the average intelligence level in both states. And that is depicted here. If you look at the left side of the graph, if this is the traditional staging with a group of patients that's doing relatively well, that you discriminate from the group that does relatively poorly, and now you bring in a sensitive imaging technique, then you take away the group that does poorly in the good group and shift them to the poor group. If you then look at survival, you see that the smaller good group does better, but you added relatively good prognosis patients to the poor group, and they also do better. So lo and behold, you haven't changed any therapy, but your survival improved. And the literature is full of this. So you have to be very, very conscious of the fact whether you truly see an effect or whether you're just looking at a recalculation of the data. So what is it all about? Reduce therapy if possible, intensify therapy if needed. A substantial number of patients is not cured with standard therapy. These patients may benefit from change, intensification, or combination of treatments to improve outcome. However, late treatment-related morbidity and mortality, especially in the combination of chemoradiation, is not trivial, and it's an important aspect in cancer survivorship. And one of the main areas that we're also looking at is to reduce therapy without compromising oncological outcome. So instead of one size fits all, I think PET-CT can help in individualized patient management strategies, so risk-adapted and response-adapted. So how do we approach the reading of our images? Qualitative reading in lymphoma is considered appropriate. And it prevents significant technical issues associated with quantification. And it prevents the absolute demand for very stringent QA/QC programs for harmonization of protocols and scanners. These are not trivial issues. If you compare two SUVs from two institutions that work in an independent, non-harmonized manner, it's basically useless. You can't use the SUV cutoff that your neighbor is using. So qualitative assessment definitely has its bonuses. And there are multiple scoring systems in use, and I'll take you through them briefly. Back in 2005, there was a paper in the Journal of Clinical Oncology with a rather complicated scoring system that's been used in combination with the IWC score, and PET was added to that. And it was shown that it did work, but it was complicated. The International Harmonization Project that was developed for end-of-treatment PET used a set of criteria where the focal or diffuse FDG uptake above background was used as the main criterion. However, we've shifted now for lymphoma reading to the modified Deauville criteria developed in 2009 in a beautiful French city in Deauville. And you're all very much familiar with the 5-point Deauville scale, which is now in use in the larger trials, but also in clinical practice. And you have to get very familiar with it when you're doing lymphoma reporting, because your clinicians really rely on it to interpret the therapeutic results in comparison to what has been described in literature. And here are a couple of examples of patients who are staged with PET, who have very PET-avid disease on the top row. And on the bottom row, you see the respective response scans. So on the left, Deauville score 1, you see that the lymphoma activity basically has gone. In Deauville scale 2, you see a very, very faint uptake remaining. In Deauville score 3, you still see some uptake, but it's equal or less to liver. In 4, you see significant uptake, which is more than liver. And in Deauville score 5, you see extensively very high uptake, more than 2 to 3 times the liver uptake remaining. And this is the scoring system that's now in use. And it immediately relates to the response criteria, where complete metabolic response is scored at 1, 2, and 3, and 3 is a bit of an intermediate. Partial metabolic response still has 4 and 5 in it. No metabolic response also is the 4 and 5, but with no change. And progressive is an increase or new lesions. And if you break down the response criteria and summarize them in a few words, 1 and 2 are okay, negative scans. 4 or 5 show this, persistent disease. And 3 is usually classified as negative because these patients do have a good prognosis with standard treatment. However, if you have these patients in a de-escalation treatment, you consider the Deauville 3s as positives because you want to prevent under-treatment when you take the treatment schedule to de-intensification. And also what is important, because we may be looking at treatment-related FDG-positive abnormalities, is that you are liberal with verification biopsy when second-line therapy is considered. What you don't want is to treat a patient with second-line therapy because of inflammatory response to treatment. The pitfalls, impact of patient preparation, timing, and scanning protocols. It makes a huge difference how you prepare your patients and when you scan. Growth factors and bone marrow repopulation are a very well-known factor that really spoil your images to evaluate the bone marrow uptake. Treatment-induced changes, for example, due to thymus rebound, so you see a thymus appearing which may mimic a mediastinal mouse. And obviously, active infection and inflammation, and the image that I've taken here is from an Indian group where you would immediately think that this patient has a malignant lymphoma. However, this patient had malaria. So being aware of these pitfalls is very, very important. So timing of your PET scan for response assessment is crucial. You take your interval PET as close to the start of the next cycle as possible. The longer you can wait, the easier it gets. You can't get too close to the next cycle because you will need to allow your hematologist some time to use the results to modify the treatment, but delay it as much as possible. Wait as long as possible after a patient had growth factors. And for a valid assessment of radiotherapy response, you may have to wait up to 3 months. When do you do your interim PET? Very early, after 1 cycle, or early, after 2 or 3 cycles. The most compelling evidence comes from interval PETs after 2 cycles of ABVD, and I will show you examples of that. Interim PET after 1 cycle will yield higher rates of positives. So that may indicate a subset of patients who have minimal resistant disease within their disease burden, but that needs additional data how to handle IPET-1 positivity. End of treatment scans, it's prognostic for patient outcome, but it's considered less optimal since the switch from ABVD to more potent regimens, such as BIACOP, should be done as early as possible. To continue an ineffective chemotherapy regimen and then switch late means that the patient has had the toxicity of ineffective treatment while you could have switched earlier to effective regimen. And there is evidence that that makes sense. So this is a summary of the early studies, which basically set the stage for the recent randomized trials that have been published. And all of them indicate that there is a potential role for FDG-PET in assessment of treatment response in the first line. So the focus of these randomized trials were, first of all, de-escalation strategies, looking at how much therapy you can delete from the regimens to prevent side effects, decreasing the number of cycles, omitting bleomycin, which has this infamous pulmonary toxicity, and the switch from very potent to less potent chemotherapy. Limiting or omitting radiotherapy to avoid the long-term side effects of it. And also the criteria for escalating to more potent chemotherapy. Which patients do need this and when do they need it? So this is a relatively early study where they used conventional PET and even gallium to switch patients on the basis of their international prognostic score risk assessment. And if the risk was intermediate, patients started on standard treatment. The risk was high, they were started on intensified treatment. And the early PET basically determined whether there would be a crossover to standard for negative PETs and positive for positive PETs to the more intensified treatment. And what you see, which is a clear indicator that the PET-driven switch of therapy makes sense, is that it didn't impact on patient survival. So apparently, taking away potent chemotherapy from high-risk patients doesn't affect the overall survival negatively, and it does help to switch over the non-responding intermediate risk patients. Then going to a more recent study in early Hodgkin's lymphoma, the RAPID trial, where they did the interim PET after 3 treatments, and that may be a little bit late, where it was assessed whether you could leave out radiotherapy in PET-negative patients. And although it didn't matter for the excellent overall survival, you do see in the left graph that a small subset of patients is actually having a relapse when radiotherapy is omitted. And that was also observed in the age 10 study, that the patients who were PET positive after 2 cycles did better if you switched them to the chemotherapy BCOP. Oh, go back. To BCOP here, so intensification of treatment does work. But on the other hand, if you have a negative PET at interim, and if you switch the patient over to the arm where you omit radiotherapy, a small fraction of these patients will relapse. So there is evidence that the negative PET is not as predictive as you would think, although it doesn't matter at all in terms of survival. The overall survival is still very, very good. So you also may offer the patient the choice whether to take the small increase of relapse for granted, because the overall survival is still good. So involve your patients in the discussion what is the best treatment for them. So switching to advanced Hodgkin's lymphoma, this is one of the hallmark papers where it was shown that independent of the prognostic score, PET positivity and PET negativity were much more predictive for progression-free survival. Study by Andrea Gallamini, published in 2007. So taking that, this is the Rathel study published in the New England Journal in 2016. And here you see that when you have the patients that respond on your interim PET, and you, instead of continuing the ABVD, if you take out if you take out the bleomycin and continue with AVD, these patients do equally well. So you can take out cytotoxic chemotherapy without impact on outcome. On the other hand, if you switch over the PET-positive patients to BCOP, they do much better than reported in literature. In the HD0607 study, you see a similar pattern that if the PET negative patients are switched, then not much happens, but the PET positive patients do much better. So if you look at the evidence in advanced Hodgkin's lymphoma, a change to the treatment paradigm is appropriate. If interval PET adapted treatment approach after 2 ABVD should become the standard of care for all patients. So positive patients should be switched to BCOP with a little bit of a question mark, because not all hematologists accept it as currently. negative PET patients can be taken off bleomycin early. Higher stages of disease have a slightly lower negative predictive value of the interim PET for ABVD, but not for BCOP. You have to remember that. And if the patients are PET negative, they do just as well on 4 cycles of escalated BCOP and as they do on 6 cycles. So you can take away safely 2 cycles. And further, what you have to remember is that the interim PET positive patients that have a significant burden of disease, so the Deauville 5 scores, they do have a high risk of treatment failure. So just the switch from ABVD to escalated BCOP may not be sufficient. So these patients may need even extra than a switch to more intensive chemotherapy. So in non-Hodgkin's lymphoma, we'll spend a few minutes on that. It may be that PET is an effective predictive biomarker in diffuse large B-cell lymphoma, but it's not accepted as the standard of care yet. There are inconsistencies in the studies, in the timing, in the regimen, and in the PET reporting criteria. And you also have to remember that 15 to 20% of the diffuse large B-cell lymphomas and almost all follicular lymphomas will relapse. A lot of false positives may occur due to inflammation and tumor necrosis. However, interval PET is better than interval CT to predict prognosis and to exclude progression. So if your hematologist wants to assess response early, it's better to do it with PET than with CT. Having said that, changing of standard treatment of interval PET in non-Hodgkin's lymphoma is not recommended outside study protocols, unless there is clear evidence of progression. So be cautious of extrapolating the Hodgkin's disease data to non-Hodgkin's lymphoma. And we may be looking at yet another classification. This is a study that's recently been published online in Blood, showing that it's not just the Deauville classification, but also the tumor bulk that may be relevant. So we as nuclear medicine physicians may be put up with a little bit of extra work, summing up all these lymphoma lesions to calculate the tumor bulk, which may be a better prognostic factor than just the Deauville score. And other agents may be tapping on the door as well. First studies with FLT show that it is distinctly different from the information that you get from FDG. So maybe FLT will help you in these difficult cases where you cannot use FDG to solve the clinical question. We have to see. Not enough clinical studies out there yet to make a decisive command on that. So coming to my final slides, concluding, I think it's fair to say that FDG PET-CT is important, provides clinically relevant information before, during, and after treatment for malignant lymphoma. I think malignant lymphoma is by far the most advanced field in oncology where PET-driven changes in systemic treatment of cancer is pursued. The body of evidence is largest in Hodgkin's lymphoma. Non-Hodgkin's lymphoma still shows a rather scattered landscape, so be very careful in how you interpret the literature. And ongoing trials on FDG PET-driven treatment change will answer the remaining clinical questions in the near future. And as we've heard from our previous speaker, with the wealth of new drugs coming to market, I think the role of exploring and underpinning the relevance of imaging is far from over, and we have a lot of work upcoming. So thank you very much. If you haven't heard enough of it, we will be meeting in October in Menton, France. First, the lymphoma group and subsequently the International Cancer Imaging Society meeting, where you can enjoy a lot more about imaging in oncology. Thank you very much.
Thank you very much, Professor Ooyen.